Поворачивайте. Ага. Двойным кликом на экран.
Так.
Двойным кликом.
Вот.
Да, нажимайте.
All the brain tumors.
Выверните.
Children. Child brain tumors.
Все?
Спасибо.
Пожалуйста. Как начать?
Сейчас начну.
Все, уже идет. Все, вам больше ничем не делать не надо. Давайте поиграем.
Все, пошел.
Lectures outline. Introduction, classification, workup, management, and revision. So, let's get to it. Here you can see classification of the brain tumors. Children, child brain tumors registered in the United States. Factors, cells. So, next one. Brain tumors. There are primary brain tumors and secondary brain tumors. Primary brain tumors, they have brain tissue origin, and secondary brain tumors, they have non-brain origin. So let's get to secondary brain tumors. As we said earlier, non-brain origin equals cancer metastasis. Most common, from 25 to 45% of cancer patients. More than 50% of all from lung cancer, breast cancer, melanoma. Less than 10%, 50% of melanoma patients, renal cell, and colorectal. Any primary tumor can metastasize to the brain. Meningeal carcinomatosis here in the image pictures you can see meningeal carcinomatosis here with yellow arrows, here with red arrows you can see this metastasis. And here is the pathologic factor. Primary brain tumors, as we said, brain tissue origin, such as melanoma 30%, astrocytoma, glioblastoma, oligodendrogliomas, oligoastrocytomas, ependymal tumors, ependymoma, PNET, embryonal tumors, medulloblastoma, pituitary tumors, tumors of cell region, adenomas 13%, craniopharyngiomas, hematopoietic tumors, lymphomas, plasmacytomas. Infratentorial versus supratentorial tumors. Here, let's remember a little bit anatomy, yeah? Tentorial, supratentorial, which covers cerebrum, and infratentorial covers, which means under, yeah? Which means cerebellar parts, cerebellum, under tentorial and above tentorial. So, 38% supratentorial tumors, supratentorial ependymoma, astrocytomas, optic pathway gliomas, pineal tumors, ectogliomas, 54% infratentorial tumors such as medulloblastomas, pelvic astrocytomas, craniopharyngiomas, epiphyseal adenomas, brainstem gliomas, infratentorial ependymomas, and 3% spinal tumors, such as astrocytoma ependymomas. So, here you can see survival probabilities for different central nervous system tumors. It's according to Germany. How do brain tumors cause problems? First, mass effects. Here you can see gigantic tumor. Here you can see its tumor compresses normal brain tumor. Gigantic tumor compresses. Here, in this case, here, compresses lateral ventricle. In this case, here. So, mass effect. Local invasion tumors invade normal brain, microscopic. Here you can see it invades normal brain because it's not normal brain. So, and the third thing is edema, swelling of normal brain. Here you can see this white part is edema, and this little part is tumor. And you can say that in this case, this tumor probably can be or must be benign. It's not aggressive. But in this case, because edema shows aggressiveness the tumor. It's bad. It's aggressive tumor because of its edema. So, next one. General presentation, generalized symptoms and signs, elevated intracranial blood pressure, personality change since following 5%, nausea, vomiting 15%, blurred vision, papillary edema, and lethargy. Headaches, of course, 50%. New or different, worsening over time, worse of awakening, then improve other symptoms. Seizures, 30%, and cognitive change, 30%. Here we can remember our anatomy of the brain. Here are enlarged lateral ventricles, yeah. Here, third ventricle, yeah. Here are also lateral ventricles, third ventricle, aqueductus, fourth ventricle, yeah. And here are rhomboid fossa, yeah, brainstem. Okay. And here you can see increased intracranial pressure. So you can see pressure capsules, and here you can see enlarged lateral ventricles, which means hydrocephalus. Yeah, disruption of hydrocephalus or cerebrospinal fluid here, because here is stenosis of the foramen Monroe, or stenosis of the third ventricle, or aqueducts, or stenosis of fourth ventricle, because of this cerebellar lesion. Here is mass effect, yeah. That's why here is stenosis, and cerebrospinal fluid cannot flow, cannot go out or get out from the lateral ventricles. That's why it's enlarging. Here, cerebellar lesion, and here you can see around it, you see perifocal edema. Next, infants. Symptoms in infants, yeah. Pathologic skull growth, bulging of fontanelle, here you can see bulging of fontanelle. Sundown phenomenon, yeah. Gaze, you can see. Squint after third month, abducens palsy, yeah. You can see here strabismus. Delay or loss of milestones. Next presentation. Focal symptoms and signs. Site-specific to location. And here we can remember our anatomy of the brain, yeah. Here, frontal lobe, parietal lobe, occipital lobe, yeah. And here is temporal lobe. Here is cerebellum. And here is brainstem. Next, presentation. Focal symptoms and signs, site-specific to location. If tumor is situated frontal lobe, personality, cognition, expressive, language, yeah. This is for what they respond, yeah, in this case. Each of the lobes represents, yeah. So, parietal lobe, yeah, weakness in coordination. If tumor is in the occipital lobe, there is problem with vision, yeah. In the cerebellum, coordination, balance, yeah. If in the temporal lobe, receptive language, yeah. So again, you can see here supratentorial tumors, infratentorial tumors, spinal tumors. Diagnosis. How to diagnose? First, one of the main parts, history taking plus PE, slowly progressive focal neurological signs and signs of intracranial hypertension, epilepsy in a patient with negative history of epilepsy, optic fundus, edema, imaging, of course the main parts, CT, MRI, PET-CT, MRI, skull X-ray, angiography, EEG, electroencephalogram, histological examination, also brain tumor tissue samples obtained either by means of brain biopsy or open surgery, definitive diagnosis. So we can see cerebrospinal fluid cytology notes no lumbar puncture before imaging diagnostics. Tumor marker FP, these things. Ophthalmology uses visual fields, eye fundus, ENT, audiometry. Endocrinology, of course, hormones, cognition, attention, fine motor skills, visual motor coordination. MRI, more sensitive density, can detect small tumors, high diagnostic accuracy, provides much greater anatomic detail, and lack of ionizing radiation. Here you can see the tumor. But its advantage of MRI and the disadvantages. Expensive, contrast media is needed, allergy, time renal failure, risk from metal objects, sedation, disadvantages. CT, advantages, pros. Less than 90% of more than 90% of tumors, more sensitive than MRI for detecting acute hemorrhage, calcification, and bone involvement. No sedation, it needs no complication. It needs no sedation, there is no complication. Disadvantages, all comes. Small tumors, tumors adjacent to bone, pituitary adenomas, glial tumors, and vestibular schwannomas cannot be detected. Radiation exposure, allergic reaction to contrast. Here you can see tumor, here is the tumor classifications. Here. Test for tumor metabolism, possibility of PET scan. PET scan is also one type of CT scan, computer tomography. Here are with these things. Analysis with FTG, oligodendroglioma. In PT scan, you can see how it's beautiful images with color. Anaplastic astrocytoma 3, grade 3, glioblastoma grade 4. Here you can see it's MRI. It's with methionine. Here you can see PET scan. Here you can see tumors. Here tumor. Here. Next. PET CT. Advantages: entire body, distant metastasis, non-invasive procedure, no sedation, no complication. Disadvantages: radiation exposure, allergic reaction to radiopharmaceuticals, expensive, less accessible. Verification. Yeah, you can see here a beautiful image of our brain. Here we can see midbrain here, midbrain. In this case, here we can see pons, but it's not tumor. So we can see this is sagittal plane, here from sagittal image, sagittal plane. Here is biaxial plane, axial plane, you can see here. We can see here also radiological confirmation. Only 45 years old female with primary tumor mass. You can see here. Color is different. Color is different. Shade of the color is different. In this case, astrocytoma grade 2. Here you can see cells. Astrocytoma grade 3. Here you can see cerebrospinal fluid analysis. You can see here is pathological verification. Metastatic carcinoma. Here normal lymphocytes, monocytes. You can see how much of cells. There are just 2 cells. Here are so many of them, cells. What are our options? First, surgery, biopsy, diagnose the tumor, and after that, resection. Diagnose the tumor, remove as much of tumor as possible. Next one, surgery, biopsy. How it's done. Pick a few weeds out. Diagnose the tumor. In resection, pull as many weeds as possible. Surgery. Questions here was we try to answer what we are trying to find, what we are trying to achieve with surgery. Where is the tumor? What bone is in the way? What brain is involved? What does the brain do? What arteries, veins are involved? Where is the tumor? Okay. What bones is in the way? What brain is involved? What does the brain do? What arteries and veins are involved? Yes. Here you can see this lesion, this tumor, and here is around this atom. You can see you can think there is someone here, but you can see it's because you see it's different from other brain tissue. It's different. It's why you can see it. You can differentiate it from the brain tissue. Here you can see something under cerebellum, like brainstem tumor, because it's different mass effect. You can see here lesion. Tumors. Here you can see also some lesion. Here, transnasal transfemoidal approach used commonly in this case. Next, here you can see this tumor. Here, primary motor cortex. That's why nowadays neurosurgeons doing tractography, and we are planning with neuronavigation how to make approach, which approach to choose. Not to injure any tracts from the brain to spinal cord or from the spinal cord to the brain. Primary motor cortex, because it's situated here, because it's here, that's why I'm choosing awake craniotomy. Surgical tools, microscope, improves visualization, increased light, it is microscope, and increased magnification. Improves surgeon comfort, adjust scope angle, instead of bending, twisting, here it is. It's microscope. Amazing thing. Amazing tool. Surgical tools, second one. Navigation, also it's awesome, amazing thing. GPS system for the operation room or for a planned surgical approach, confirm anatomic position, brings radiology data into the OR, functional MRI, white matter tracks. Set tractography, here you can see tractography. Here you can see approach, or you can do it. Here you can see the nipple of it. Here problems, you can write here your data, MRI, CT images. Next one, robotics. Here it's robot, Da Vinci, these kinds of things. Navigation systems with built-in surgical assistant. Pre-plan surgical approach, utilize the robot to align the instruments. Minimally invasive, as you can see. Less than half centimeter. Minimal invasive, single stitch incision, maximizing precision. You can see here. Now it's beautiful. Now it's minimal invasive. After that, laser ablation. Also minimal invasive, single stitch incision, as you can see here. Pass a probe into the tumor, reduce risk to normal brain, and utilize heat to destroy tumor cells. Utilize heat to destroy tumor cells. Use preoperative image. Here is tumor here. And here is 1 year post-operative. Here. Next, what are our options? Second part, second option. Conservative treatment. Radiation therapy, chemotherapy, and palliative care. Radiation therapy, EBRT. Disadvantage here. Skin irritation, hair loss, nausea, fatigue, tiredness, brain edema, local regional deficit, age, mental retardation, intellectual retardation, impairment. Intellectual impairment. Gamma knife, as you can see here, it's like ionizing. Small tumors. Radiation therapy. Regimen come from radiation therapy. Neoadjuvant, adjuvant and palliative radiotherapy. You can see here. Radiation therapy. No clean margins, can never pull every single bit. Whole brain radiation. Multiple small doses to entire brain. Slight disadvantages. The best option is, or better option is, stereotactic radiosurgery, so SRS. High dose to small area limits exposure to normal brain. It's localized, it's more local to brain tumor. Chemotherapy, let's get to it. Chemotherapy regimen. Neoadjuvant, adjuvant, palliative chemotherapy. Preparates such as temozolomide, inhibition of DNA synthesis, induce apoptotic death, myelosuppression, emesis, lomustine, intracellular derivative, and the methotrexate therapy preparates. Disadvantages or cons: hair loss, alopecia, mouth sores, mucositis, loss of appetite, nausea, vomiting. Most commonly symptoms: diarrhea, increased chance of infections, neutropenia, bleeding, thrombocytopenia, fatigue, anemia. Palliative care. 5-year overall survival rate. Also reached in the United States. You can see here survival rate. In young patients, high rates of survival, probability survival rates. And other patients, there are less chance of survival rates. What you need to know: 3 most common primary brain tumors in adults, 3 histologic features defining glioblastoma, why low-grade brain tumor can have a poor prognosis, 2 most common brain tumors in children, and 2 hereditary syndromes associated with brain tumors. 3 common primary brain tumors in adults: meningioma, pituitary adenoma, high-grade astrocytoma, grade 3 anaplastic astrocytoma, grade 4 glioblastoma multiforme. 3 histologic features of defining a glioblastoma: mitosis, tumors, endothelial proliferation, necrosis with pseudogen palisading. Why a low-grade brain tumor can have poor prognosis? Location, location, location. Because of its location. 2 most common brain tumors in children is pilocytic astrocytoma, grade 1, and medulloblastoma, grade 4. 2 hereditary syndromes associated with brain tumors: neurofibromatosis 1 and neurofibromatosis 2, type 1, optic neurogliomas, P-optic chiasm, and neurofibromatosis type 2, acoustic neuromas, meningiomas, ependymomas. Now test yourself by playing. Let's get to it. Name the tumor. Here you can see pituitary gland here, as we remember. Well, I hope you remember anatomy. Pituitary gland here is, and its causes here: pituitary adenoma, acromegaly, may present with endocrine abnormalities, as I said. Acromegaly presents with bilateral temporal hemianapsia. Here's the tumor: pituitary adenoma. Approach will be transnasal approach. Best option. And the tumor most common in age was 60 years. You can see very malignant butterfly lesion, as you can see, butterfly lesion. For its glioblastoma, you can see it's here, glioblastoma. Second most common brain tumor arises from arachnoid capsules. Here you can see it. It's white color. It's meningioma, benign tumor, meningioma. Most likely PNT tumor, high hemorrhage-sensitive. Second most common tumor in children. You can see here, medulloblastoma. You can say, because medulloblastoma, as you can remember anatomy, it's brain stem. In English it's called brain stem. In Latin it's called medulla oblongata. That's why it's medulloblastoma. Here. Can cause Lockton syndrome, neurofibromatosis 1,